Good afternoon, everyone, and thank you for joining today's webinar on Bi-Directional Referrals to the National Diabetes Prevention Program. I would like to introduce Mamta Gakar, Director of Program Delivery and Impact at the Evidence-Based Health Interventions Division of the YMCA of the USA, to introduce today's speakers.
Hi, everybody. Thank you, Matt, for that introduction. Just wanted to thank everybody for joining us today for the final webinar in our three-part webinar series. As a reminder, for those who maybe weren't on the first two webinars, this series stems from work we've been doing as part of a cooperative agreement with the Centers for Disease Control Division of Diabetes Prevention. The series is designed to provide National Diabetes Prevention Program providers and healthcare providers with an overview of how electronic health records and supporting tools and systems are currently being used in the field for type 2 diabetes prevention. This webinar will also provide an overview of current challenges facing the electronic health record, or EHR, landscape, and potential new and emerging EHR-related technology that can be used to overcome those challenges. Today's webinar will be facilitated by our colleagues from the American Medical Association. AMA has worked closely with YUSA in evaluating the healthcare system side of the bidirectional e-referral process. Their webinar targets healthcare systems and healthcare providers, and the purpose of their webinar today is to describe methods of referring patients with prediabetes to lifestyle change programs that are part of the National Diabetes Prevention Program. The webinar will cover systematic approaches to screening and identification of eligible patients, referral mechanisms, and approaches to closing the referral loop, highlighting key challenges and emerging best practices. Today's speakers are Linda Murakami and Kate Curley. Linda Murakami is a registered nurse with a clinical background in medicine and oncology. Linda has extensive experience implementing quality improvement programs in healthcare settings. She serves as Senior Program Manager at the American Medical Association, overseeing the practice facilitation component of AMA's chronic disease programs. Kate Curley is a practicing family medicine physician serving as Director of Chronic Disease Prevention at the AMA. She provides clinical leadership for AMA's chronic disease programs and has several years' experience guiding healthcare systems in developing and implementing diabetes prevention strategies. I'll now turn it over to Linda to begin today's webinar.
Thank you. So thanks for allowing us to join you guys today. We're just going to review our objectives, describe the key components of prediabetes identification and bidirectional referral processes to lifestyle change programs that are part of the National DPP Diabetes Prevention Program, review different approaches or examples of utilizing technology solutions to facilitate the identification and referral processes, discuss the key barriers that health systems may encounter and key considerations when implementing technological solutions to facilitate bidirectional referrals to LCP, and outline recommendations and emerging best practices for the healthcare organizations with different levels of HIT, health information technology, sophistication. So the AMA partnered with the Y in an effort to find ways to perform bidirectional electronic referrals so that healthcare providers could easily refer qualifying patients to the lifestyle change programs at local YMCAs. Small teams at the AMA, along with stakeholders at the Y and the CDC, met with healthcare providers in person and on the phone to investigate how current process systems that are in place are working and when they're initiating these referrals to these programs. Discussion also included methods for communicating patient updates from the YMCAs back to the healthcare provider teams. These teams provided an understanding of what works, the barriers they encountered when establishing electronic referrals, and how they're communicating. So we're going to now discuss the prediabetes identification and LCP bidirectional referral process. But first we want to kind of talk about why we're here today and why we need to develop these processes for referring patients to programs to prevent diabetes in the first place, or preventing type 2 diabetes. There's 84 million American adults that have prediabetes, and prediabetes is defined as people who have elevated blood sugar, but it's not high enough to be diagnosed as diabetes. Typically, these patients have an A1C of 5.7 to 6.4, or a fasting blood glucose between 100 and 125, or an oral glucose tolerance test result of 140 to 199. Those who have it are at increased risk of developing type 2 diabetes unless they adopt lifestyle changes that reduce weight and increase physical activity. So while we talk about the millions who have prediabetes, 9 out of 10 are unaware that they have it. Cardiovascular and renal risks show a high prevalence in people with prediabetes. Once diagnosed with diabetes, 100% of these patients are more likely to develop hypertension. The economic burden is estimated to be $237 billion in direct costs in 2017. Working to get patients to the clinic and have regular checkups and blood work are vital in identifying patients in this population. There are 3 standard ways to test for prediabetes. Draw blood for an A1C, a fasting glucose, or perform the glucose tolerance test. You can see listed on the slide what defines prediabetes for each type of the tests. Risk factors for prediabetes mirror those of diabetes. These patients are overweight or obese, have increasing age, have a family history of type 2 diabetes, fall into the population of racial or ethnic minorities, and live sedentary lifestyles. Studies show that for patients who have prediabetes, they're aware of it and participate in lifestyle changes through structured programs, reduce their risk of developing type 2 diabetes. Active participation in lifestyle change, which means dietary changes and increasing physical activity, was found to be more effective than taking a glucose-lowering medication such as metformin. And while metformin has not been approved by the FDA for use in preventing or delaying the onset of diabetes, recent guidelines by the American Diabetes Association recommend considering the use of metformin in patients with prediabetes, especially in those who are under 60 years old, have a BMI of greater than 35 kilograms per meter squared, or have a history of gestational diabetes. Here are the guidelines from the United States Preventive Services Task Force, also known as USPSTF, providing a grade B recommendation for screening every 3 years. Screening is based on age and body mass index, or BMI, using the methods we mentioned previously of an A1C, fasting glucose, or glucose tolerance test. Again, those with abnormal results identifying prediabetes should be referred to programs for diet and lifestyle changes, such as the lifestyle change programs that are part of the National DPP. Now we'll start to talk about how you can operationalize this guideline into practice. First, we'll discuss the process to screen and identify patients with prediabetes. Then, we will cover processes for managing these patients with referrals to LCPs and closing the referral loop. So step 1, we're going to start with here, but we're going to run through this 4-step algorithm for identifying patients. First, you need to determine who will be screened. We will exclude anyone under age 18, people who have already been identified as having diabetes, and women who are pregnant. This could be found in the electronic health record or the EHR, or through lab values, or on the patient's problem list as a current diagnosis. Once you've identified the patient population that would be eligible for screening, check labs drawn for the last 12 months and determine if any previous screening for diabetes or for glucose screening test is present. If there's not, you'll move to step 3, and if there is, you'll move to step 4. When you get to step 3, you'll find a category that applies to your patient. Under A, the general population, you'll check to see if the lab criteria we previously mentioned under the USPSTF guideline. You'll also have the option for your patient under ADA criteria or the risk test at doihaveprediabetes.org. If no lab test was done in the last 3 years, you'll want to order one of the 3 lab options we've been describing: hemoglobin A1C, a fasting glucose, or a glucose tolerance test. If your patient's previously been diagnosed with prediabetes, they'll fall into category B, and will also need one of the 3 recommended lab tests. Lastly, your patient will fall into category C if they had a history of gestational diabetes also referred to as GDM. If one of the three lab tests should be performed, one of the three lab tests should be performed if one has not been done in the last 3 years. Overall, if the patient falls into the general population or has gestational diabetes category, labs should be checked every 3 years. And if they have a history of prediabetes, you'll need to do annual testing. Here again are the labs and their correlating categories for the results. You'll need to interpret your results, then manage it based on recommendations moving forward. We'll cover management of these patients later in the presentation. We also want to be sure to stress that once you've diagnosed your patient with prediabetes, be sure to document the ICD-10 code onto the patient's problem list. There are two overall approaches here. It's helpful to have your workflow to identify the patient. Know that the care management approaches help leverage identifying patients by running corresponding reports through the EHR. You can do this individually for patients you are going to see, or identify patients as a group by running a query to identify all qualifying patients in your panel. You can also combine these approaches, as this may be helpful for clinical settings that do team huddles prior to patient visits, identifying patients that will or may need labs done as a means to diagnose or rule out prediabetes. If you're using a team-based care approach, know that you don't need to rely solely on your providers or physicians to manage this process. Running the reports, reviewing lab results, or performing patient outreach can be delineated to many other members of the healthcare team. Those interested in more information on team-based care, pre-visit planning, and pre-visit lab testing can go to stepsforward.org. This website has modules that can help you build these processes into your workflow. And here's information to help you build a query for identifying patients through your EHR. We've included the ICD-10 codes and the link codes for lab work in this table, as we hope it helps make it easier for you to perform. Be sure to use both the inclusion and exclusion criteria listed in the table for accurate reporting.
Thanks, Linda. So this is Kate. And now that Linda's covered the identification process to determine which of your patients might be eligible to participate in a lifestyle change program that is part of the National Diabetes Prevention Program, I'm going to switch gears and spend a lot more time talking about how we can make referrals from the healthcare provider to the lifestyle change program, as well as how we can close that referral loop by receiving feedback information from that lifestyle change program provider. So before I jump into talking about the actual referral process and how to create a referral pathway, let me just quickly cover the basic information that should be included in a referral order for an LCP. So obviously, with any referral, you're going to need to include patient information, including the patient name and basic demographics like a date of birth. It's also very helpful for the lifestyle change program provider if you can include up-to-date contact information and a preferred method of reaching that patient, because the lifestyle change program is going to want to reach out to that patient after they receive the referral from the healthcare provider. Of course, as with any referral, you also want to include the physician name and the physician contact information so the lifestyle change program provider can reach out to the physician with any questions, and so that they know where to send their feedback reports once they do receive that referral information. Lastly, it's extremely helpful if the healthcare provider can include clinical information in that referral that establishes how the patient is eligible for participating in the lifestyle change program. So most often that would include a lab test result, so again, that hemoglobin A1C or fasting plasma glucose, or if you're doing it, the oral glucose tolerance test. So what was the result, as well as the date of the test. Linda also briefly mentioned the doihaveprediabetes.org risk test or risk screener. We didn't go into great detail about this, but patients can be eligible to participate in a lifestyle change program if they have an elevated score on that risk screener. Most healthcare providers are identifying their patients by conducting a lab test, and that's definitely what we recommend because we do know if a person has an elevated score on the risk test, they are at risk for having prediabetes or undiagnosed diabetes, and you want to confirm that with a laboratory test. However, some healthcare providers are using the doihaveprediabetes.org risk test as a way of engaging patients in their health and understanding their risk. Some healthcare providers have actually sent the risk test to patients via the patient portal. And so if you do have a patient population that you've identified as having an elevated risk score, you can refer those individuals as well. And again, including that information about the risk test result on that referral is very helpful so the lifestyle change program provider can verify how the patient is eligible to participate in the program. So now let's talk about the actual process for making a referral from the healthcare provider to the lifestyle change program. And I find it helpful to break this down into two major steps. The first being the order entry or the actual referral form generation or referral order generation. And the second major step is actually transmitting that referral from the healthcare provider to the lifestyle change program. And you can see here that there are multiple different ways to approach each of these steps. So when it comes to generating that referral order, really the preferred way is to create an electronic order or an electronic form within the EHR, so within the electronic health record. And that order or form could include some auto-generated fields. So you can develop a form where that lab test result is automatically pulled into that referral order, saves the providers a little bit of time. Or you could have fields that are manual entry that require the healthcare team to actually enter information into that referral order. Most referral orders or referral forms are going to be a combination of these types of information, but ideally it's captured within the electronic health record so that there is a long-term record that the referral was actually made and the service was requested. And ideally that order form contains as much structured information as possible so that it's searchable and discoverable later. An alternative, if it is too time or labor intensive to create an electronic order, an electronic form, would be to simply use a paper referral form. That's what we always used to do, and sometimes that's a helpful approach just to get things rolling at your organization. But again, I would note that that electronic order is really the ideal for making these types of referrals. And then there's the referral transmission piece, and that can be done completely electronically, which was really the goal of this project, and we'll talk about how that was difficult to achieve in a moment. Alternatively, the referral order can be auto-faxed from the EHR to the lifestyle change program provider, or it can be printed, or that paper form can be manually faxed. So now I want to walk through sort of how you can combine these different order entry and transmission approaches to actually create referral pathways. So first, let's talk about that electronic referral, by which I mean a completely electronic process, end-to-end electronic process. So this, I would say, is the most difficult to achieve, but probably the easiest for the healthcare team to actually utilize once it's been built and developed. So in order to have a completely electronic referral process, this requires some type of electronic interface between the healthcare provider's EHR and the lifestyle change program's EHR or electronic data management system. So I should note here that this was possible in this project because the YMCA is utilizing an EHR to manage their lifestyle change programs. This may not be true with all lifestyle change program providers, although increasingly many of them are using electronic systems that allow them to receive referral orders. But an electronic interface of some sort needs to be established between the healthcare provider and the lifestyle change program. In the case of this project, we were only actually able to, we only observed a complete electronic referral process with one healthcare provider lifestyle change program pair. And in this case, they used the direct messaging functionality that was part of their EHR to accomplish this. So you need to have that electronic interface available. And then you also need to be able to create that electronic order, that electronic referral form, which also has to include with it specifications for how that referral information will get transmitted from the healthcare provider EHR to the Lifestyle Change Program's referral management system, or electronic or EHR. And then, as I said, this is a somewhat intensive process to actually build or develop this pathway, but then once it is established, it's relatively easy for the healthcare providers to then complete those referral orders and then automatically transmit the referral order over to the Lifestyle Change Program provider. So that's the first example of a pathway that can be created. The more common pathway that was used in this project was for the healthcare provider to create that electronic order or that electronic referral form and then to transmit it to the Lifestyle Change Program provider using an autofax, something that we use a lot in healthcare these days. And so again, in order to accomplish this, you need to have the ability to create that electronic order. You can use a combination of auto-generated fields or manual entry fields, but again, with that electronic order, you want to make it as structured as possible. And then you still need to include some specifications for how to send that order to the Lifestyle Change Program provider. So the order will need to include, or the specs will need to be documented for what is the destination of that autofax that's going to take place. A little bit easier, it would seem, for healthcare providers to actually create this referral pathway. And it's still relatively easy, actually quite easy for the healthcare team to use this referral pathway. Again, they just go in, they enter the relevant information into that referral order, and then when they sign the order, it gets autofaxed over to the Lifestyle Change Program provider. And then the last referral pathway that we explored was really a manual fax process. And there were two ways that this can take place. So one would still be to make that or create that electronic order, that electronic referral order, which then gets completed by the healthcare team, and then it gets printed. And so then that piece of paper actually gets manually faxed over to the Lifestyle Change Program. And as I noted before, the other way to approach a manual fax process is to simply create a paper form from the beginning, complete that paper form, and then fax that paper form over to the Lifestyle Change Program provider. Probably the least desirable approach because you don't have that documented referral captured within the EHR unless you were to scan that paper into the EHR. But in some ways, it's the easiest to get started because it requires the fewest IT resources to get that type of pathway up and running. So that reviews our three sort of major referral pathways that we observed with this project. When it comes to actually implementing a workflow on the clinical side, as Linda already outlined on the identification step, the referral step can also involve two potential major types of workflows, one being the point of care workflow. This is what the care team is doing when the patient actually comes in for an office visit and is in front of the care team. As Linda outlined, it does not need to be the physician or the provider who does everything in order to generate and send that referral. Medical assistants and other team members can be very helpful to tee up that referral in the system, perhaps during the rooming process. The healthcare provider can then later sign that order and allow that order to get transmitted. We've also seen some organizations develop some clinical decision supports. So for example, alerts that pop up when the patient is in the office, notifying the team that this patient is eligible for a Lifestyle Change Program referral, and then pushing the team towards an order set or an order that can be completed. So providing that reminder to the team that this patient is eligible to receive that referral. And then the care management approach is sort of any type of approach that the care team might take to identify patients and refer patients when they're not directly in front of them for an actual patient appointment or a patient encounter. And so the care team, whether it's a care manager or another member of the team, can run reports to find those patients who are eligible for a referral to the Lifestyle Change Program. And then a member of the team can conduct outreach to the patients to notify them that a referral has been made and that a Lifestyle Change Program will be reaching out to them soon to get them enrolled in a program if they're interested. You can do that outreach through the patient portal, through phone calls, or through mail. I'll note that we have sample scripts and letters on the Prevent Diabetes Stat website. I'll have that link up at the end of the talk. So if you're looking for some example outreach materials, we do have those on the AMA CDC Prevent Diabetes Stat website. Quick note about the messaging, though. If you're taking the care management approach to refer patients, to refer groups of patients, and you're going to send them some sort of outreach message to notify them that they're eligible for the program, sometimes this is the first time that they're learning of their prediabetes diagnosis. Their physician may not have informed them of this diagnosis before. So you have to be careful as you're developing that messaging to the patient. You want to make sure that you have a clear explanation about what the diagnosis means, and you also give the patient information about how they can contact their healthcare provider if they have questions or if they want to discuss this diagnosis more before they consider enrolling in a program. You just want to make sure that the lifestyle change program provider is not the one left explaining the patient's prediabetes diagnosis to them or taken by surprise because the patient has not actually learned before. So just a note of caution, you want to be careful in the messaging, but it can be done well, and we've worked with a number of organizations who have performed outreach to patients in this way. So now that I've talked pretty extensively through the process of making the referral from the healthcare provider to the Lifestyle Change Program, I want to talk for a few moments about closing that referral loop and actually receiving information back from the Lifestyle Change Program provider about enrollment and about patient progress. So we recommend that when a healthcare provider organization is setting up the process to make referrals, that you have some pretty detailed conversations with the Lifestyle Change Program provider about what types of information they can share back with you and when they can send reports. So first of all, you want to make sure you're requesting from the Lifestyle Change Program provider information about whether or not the patient actually enrolled in the program. So if you send a referral, you want to know that that Lifestyle Change Program actually outreached to that patient. Were they successful in their outreach? Did they never reach the patient, or did they reach the patient and then the patient declined to enroll, or did they actually get that patient enrolled? So you want to request reports that outline what the result of that enrollment attempt was. And then for patients who do participate in the Lifestyle Change Program, you want to request some feedback about patient progress at regular intervals. It's really up to the healthcare provider and the Lifestyle Change Program to work together to determine what those appropriate intervals are. Common ones that we have seen used are for the Lifestyle Change Program to send feedback about 8 weeks after enrollment or 9 weeks after enrollment, and then about 16 weeks after enrollment. Those are sort of key time points in the program. And then in terms of what types of data are sent in that feedback, what the healthcare providers really want to see boils down to some information about the patient's attendance. So are they showing up pretty regularly? Are they missing sessions? And then what is their progress towards achieving their weight loss goals? Are they beginning to achieve the 5% weight loss that is really the goal of the Lifestyle Change Program? We're showing here a sample progress report that can be used. I think the most important things are sort of those dashboard statistics about the weight change and the attendance. We also put in an example table that can show weekly progress. Some healthcare providers like to see that. They can just kind of skim that table to get a sense for to what degree the patient is actually participating, but that level of detailed information is not always needed by all healthcare providers. So the take-home message is really for the healthcare practice and the Lifestyle Change Program to talk early and work out what types of information can be sent back and at what intervals that information should be sent. So now that we talked through all the processes for both identifying patients who can participate in the Lifestyle Change Program, for making that referral, and for closing that feedback loop, we want to share with you what the experience was of the healthcare providers who participated in this project with the local YMCAs. And we'll boil it down to some of the key barriers and challenges that they encountered, as well as some key considerations. And then after we talk through some of the challenges, we'll talk through some of the emerging best practices that we saw in this project. So this is kind of the quick snapshot list of the major challenges or issues that were encountered during this project. Many healthcare provider organizations talked about competing priorities and these resource needs that were required to launch the project. We saw that EHR sophistication really varied from healthcare provider organization to organization. Interoperability kept coming up as a major challenge in successfully implementing a completely electronic process. And data security and data handling issues also came up in discussions as well. And then there was a lot of discussion about the importance of doing healthcare provider awareness, engagement, and training. And so these are all some issues we'll talk through just in a little bit more detail now. So competing priorities, what were healthcare providers talking about when they spoke of this issue? First of all, I would say that every healthcare provider, practice, or organization that we spoke with, and for a little more context, I'll mention that this included small practices all the way up to large healthcare systems. Everyone that we spoke to talked about the importance of moving from volume to value-based care, the challenges associated with moving from volume to value-based care. They were all sort of feverishly working on implementing new processes and building new infrastructure to be able to do this successfully. And I would say that they all recognized that diabetes prevention should fit into value-based care, but they were so focused on some of these higher level changes that needed to take place at their organizations that for some of them it was really difficult to focus on this specific condition or this specific project. The healthcare providers all noted that when they were interacting with an individual patient, sometimes they just had more pressing clinical conditions to deal with, like hypertension or like significant pain, significant knee pain perhaps is an example. And they were always more likely to address the patient's concerns during a visit rather than their own agenda. So as those of you who are physicians like myself, you'll know that patients often come in with a long list of issues that they'd like to take care of. And we're always going to prioritize the patient's concerns over diabetes prevention if we're forced to make choices about how to use our time, even though we recognize that diabetes prevention is important to address. The healthcare providers also spoke about how there were no available quality measures, so no way to really measure their performance in this area, and no incentives associated with working on diabetes prevention. So this was a common theme that came up as well. And I want to share that the AMA is in the process of developing some quality measures related to diabetes prevention that we anticipate launching hopefully early next year. So those will be able to serve as a basis for healthcare providers to be able to measure their performance related to diabetes prevention and hopefully start to serve as a sort of backbone for incentives to be built. But in the context of this project, there really was no measurement or incentive available to the providers, and so that made it difficult for them to prioritize this topic. So we learned a lot about resource needs, which was a key consideration for all of these organizations. Launching e-referrals certainly took up a certain amount of staff time, and it involved a number of different types of staff members. So of course, someone needed to be identified to provide administrative support, and for many of these projects, pretty significant IT support. Team members needed to participate in identifying patients, generating the referrals. Other team members needed to provide patient education and participate in that information sharing with the lifestyle change program. So there were definitely staff resources that needed to be devoted to making this project successful. They also needed to devote resources towards training of the healthcare team, including finding facilitators, creating materials to be able to do this. And then there were budget considerations as well, certain startup costs, particularly in the cases where some of the healthcare organizations were actually considering using technology outside of their EHR to facilitate making the referrals. And we'll talk more about that in a couple minutes. So EHR sophistication, as I said, the healthcare providers that we worked with really sort of varied in their EHR sophistication in terms of how complicated some of the builds were that they needed to do for this, as well as their ability to take on customization efforts and be able to actually execute those efforts quickly. As we all know, most EHR vendors offer some sort of functionality that can be used to make referrals to lifestyle change programs, but it pretty much always requires some degree of customization. And that customization can be relatively time-consuming and resource-consuming. And in certain cases, because of competing priorities, the healthcare providers just couldn't devote the resources towards that type of custom build that they wanted to do. So that was a common challenge that we encountered. Or they could devote the resources, but they were going to be on a wait list, and it was going to take significant time to actually get that customization done. A note about when healthcare providers consider using technology outside of their EHR or third-party apps. So we've learned from healthcare providers that they strongly prefer to contain as many processes as possible within their EHR. It's easier within their workflows. Nobody wants to remember a separate password to sign on to some other portal to do something when they're in the middle of taking care of a patient. Many healthcare providers simply won't do that. They strongly prefer to keep things within their EHR. However, if it does allow them to address a significant gap in care, or it truly offers, a benefit or a value to the practice or to the patients, they may consider actually using a solution that is external to their EHR. But we heard from the healthcare providers that they were really only willing to consider this if they could use that external solution for other types of high priority health conditions. So people did not want to invest in a solution that was just going to be used for prediabetes. They wanted to consider solutions that they could use for hypertension, for diabetes management, for other high priority conditions for their organization. Interoperability, common buzzword that we all like to complain about these days because it is a significant challenge, and we definitely saw this a lot in this project. It's one of the major reasons that most of the healthcare provider and lifestyle change program partners were not able to establish a completely electronic transmission process between the EHR systems. Or as I said, in one case, direct messaging was able to be utilized between one healthcare provider and one lifestyle change program pair. But for the most part, when the organizations explored this possibility, it turned out to be more complicated than they thought it was going to be. It was going to take significant resources to actually establish it. And because of the significant sort of time and human resources needed, they ultimately decided just to not bite it off. And they were able to relatively easily do that auto-fax, and so many of them pursued that path because it was sort of the path of least resistance because of these interoperability challenges. Data security and handling was an interesting topic because it was viewed differently from healthcare provider to healthcare provider. So some healthcare providers did have concerns related to privacy and data security when it came to transmitting information from their organization to a lifestyle change program provider. These concerns could be overcome with a business associates agreement. But different organizations seem to interpret HIPAA differently and have different standards or different requirements to view themselves as being compliant with HIPAA. So some organizations required or wanted a consent from the patient to be able to send the information. Others felt that that consent was actually already captured when the patient consented to receive care from them, and so they did not need an additional consent to send that referral. So again, different organizations handled things differently. We also saw that healthcare providers wanted to treat the information that they were receiving from the lifestyle change program differently. So some healthcare providers said, I would love structured fields in my EHR where I can just receive that weight from the lifestyle change program, and there it is in my EHR. I can see that as the new patient weight. Whereas others said, no, I would not want a field like that. It needs to be tagged as information that came from outside of our system, and so it would have to sit in a different place within our EHR, and we don't know how to create that, or we don't have the time and resources to create that. So we definitely saw some variability in how healthcare providers wanted to treat the information that they were receiving back from the lifestyle change program provider. Okay, so now that I spoke about lots of challenges and made it sound like it's extremely difficult to get bidirectional referrals up and running, I want to share that actually the organizations were pretty successful in getting this rolling. It maybe didn't follow the path that they thought it was originally going to take, but they were able to get up and running with making referrals from their organization to the local YMCAs. And I think we were able to identify some emerging best practices along the way that we want to share now. So first of all, you want to approach this type of initiative like you would approach any other new effort and really put some solid project management approaches in place around this initiative. So start out by identifying that project team, and we'll talk in a moment about who should be included on that project team. You need to work through what is the lifestyle change program offering going to be for your organization. Is it internal? Is it external with a community-based organization, or a combination of these possibilities? You need to have an explicit plan for how you're going to train the healthcare team on the processes that you develop. You need to be able to devote resources and people towards identifying patients. You need to have a patient engagement process clearly defined and implemented. Of course, you'll actually generate that referral, and you'll establish a process for getting bidirectional feedback back from the LCP. So those are the key sort of project plan steps that you'll need to work through. So who should be on your team? Obviously, with any good team, you're going to have a project lead who's going to be responsible for keeping track of all the things related to the project and the implementation. A physician champion is really, really important. We saw in this project, and at AMA we've seen in a lot of our other work. And I will fully acknowledge that it does not need to be a physician. It can be another clinician, but what's important is it needs to be somebody who's passionate about the topic. It needs to be somebody who can navigate upwards in the organization to gain buy-in from the leadership and gain that commitment from leadership. And then this person also has to be able to navigate horizontally to get other members of the team excited and engaged. You want to use your champion frequently to support the training of the care team. And then you also want to use them to give clinical input into any type of decision that is clinically related. So use your champion to weigh in on the identification process, the referral process, and workflows there. You also want to have a population health coordinator or manager and or that practice manager or practice leader. These individuals are going to provide a lot of input into the referral workflows, the different roles and responsibilities of the different care team members at different parts of the process, and you really need their engagement throughout the project. We spoke a lot about IT needs, so of course you're going to need that health IT staff person involved in the project. And that's to develop the orders that are needed to be placed, as well as some other functionalities in the EHR that can be used, like registries, like clinical decision support or alerts to remind care team members about what they should be doing when they see a patient. And then don't forget, marketing and communication staff can be extremely helpful in identifying or developing that patient outreach strategy and helping to develop some materials that can support your patient awareness and outreach efforts. So additional best practices that we saw, and this relates back to the fact that healthcare providers are dealing with so many other competing priorities. So to the extent that you can, tie this effort into existing organizational priorities. So a common approach that we saw was that most healthcare providers were very focused on their type 2 diabetes management. Many of them realized that prevention is really the first step in type 2 diabetes management. And they had developed lots of infrastructure, lots of processes for managing type 2 diabetes better that they could actually leverage to prevent type 2 diabetes. So tie this effort into other organizational priorities and use some of the infrastructure and processes that have already been developed for those other priorities. When it comes to identifying patients, work with sort of all the pieces of health IT that you have available to you. So I've mentioned a couple times, you can pull reports, you can develop registries, you can use clinical decision support to flag patients who are eligible for that referral or who need to have a screening lab test done. So kind of pull out all your stops if you can to kind of come at this from a number of different directions. Use the care management approach if your staffing allows it. So pull those reports, do outreach to groups of patients, not just individual patients as they come into the office, but make sure you have a solid point of care workflow together as well. And as you're getting started, you don't need to go kind of whole hog. You don't need to pull out all the bells and whistles for your first set of referrals. Get it rolling using the processes that are most familiar to your organization and not terribly resource intensive, just to get the ball rolling and to start to get some experience. But then be thinking about how you can build out the process, add the bells and whistles that will help improve the process as you move along. For that referral process, like I said earlier, the most common process that we saw used was to create that electronic referral order and then to auto-fax it to the local lifestyle change program provider. We did see a nice workaround. One organization was struggling to actually create that electronic order within the EHR, and so instead they developed a smart phrase that could pull in the key pieces of referral information into a text document. And I think it's very helpful to have a smart phrase like that that could potentially be used to populate the patient instructions section of an after-visit summary. And then what you can do is that patient then has the referral information in their visit summary, so they know what is happening. But you can also just print an extra copy of that and use that, that text that was developed to just fax directly over to the Lifestyle Change Program. So that was a nice workaround for a healthcare organization that was struggling to create that structured electronic referral order. We also saw that several of the more savvy healthcare providers started reaching out to other departments in their organization, other specialties, to see if they were using other referral management solutions that they were not aware of in their own department. For example, at one organization, the ophthalmology department was starting to explore a new referral management solution that they were finding helpful. And so this organization started exploring whether or not they could use this for referrals to lifestyle change programs. So get out of your own department and see if anybody else at your organization is potentially using a solution that could be helpful here. Engaging stakeholders early, I think this is true with any new initiative, but definitely important in this project, and recognize that some of the stakeholders are outside of the healthcare provider organization when you're dealing with a community-based lifestyle change program. And the sooner you connect with that program and talk with them about what they are able to do, you're going to develop that referral process faster. They may have some creative ideas for you that you are not actually thinking about at your own organization, and you want to make sure that you understand what their requirements are in terms of the type of information that they need to receive and what types of information they can share back with you. Identify that coach or that champion. I spoke about that at length already, so I won't go into much detail here, but again, you want to be able to use that champion for a number of different activities. It's very important to have that champion on your team. Care team education and training, that was something that was very important. You can't just build the referral pathway and then hope people will use it. You really need to devote some time towards formal training, and you want to cover information like, why do we care about this? What is the evidence behind the program? What are the guidelines that support referring to this program? And then you want to talk about what they actually need to do, what each team member's role is in the process, and make sure that they actually see the order in the EHR, that they actually know how to use it. And I would suggest baking your training into kind of standing meetings that you already have at your organization, whether it's a monthly practice meeting, a quarterly department meeting. It's typically easiest to reach your care team members if you leverage a meeting time that's already in place. Data security. As I said, a lot of healthcare provider organizations kind of had different interpretations about what the requirements were here, but certainly executing a business associates agreement between the healthcare provider and the lifestyle change program can really help to make sure that you are staying compliant with privacy issues. And then probably the most important takeaway or the most important best practice that we can recommend is to take a phased approach. So leverage technology where it's doable, where it's relatively easy to do in the beginning. But if you need to, just to get referrals rolling, start with a low-tech process. Build your relationship with that lifestyle change program provider, start to demonstrate outcomes, start to get a feel for what your patients are experiencing, and then get more sophisticated using technology to support that process. This can help you avoid investing in developing a referral pathway that ultimately doesn't make a lot of sense for your healthcare providers, your patients, and the lifestyle change program. So if needed, start low tech and then build from there. We heard from many healthcare systems that they're really trying to solve these problems related to interoperability. They're trying to figure out how they can better share information with other healthcare providers that are outside of their organization. And several of them viewed this project as sort of a good case study or a good use case for testing out new approaches. So I think that's another approach that you can take at your organization to prioritize this project. Use referrals to the lifestyle change programs as that test case to develop new processes for sharing information with other healthcare providers. And so that really wraps up our presentation portion of our webinar today. Before we move into a Q&A session, I just want to highlight that we have several resources available to help you in this effort. For healthcare providers, the Prevent Diabetes Stat Toolkit, which is found at preventdiabetesstat.org, has a number of materials that can support you in determining how to develop your identification referral processes at your organization. Lots more information about the National Diabetes Prevention Program at the CDC's website, as well as the YMCA's Diabetes Prevention Program at the WISE website. Plus, some really great engaging consumer awareness materials that you can actually use as patient engagement materials at the doihaveprediabetes.org website. And we don't have it listed here, but Linda did mention earlier the Steps Forward modules, which is stepsforward.org, right, Linda? And that has some really great practice facilitation or practice management modules, pre-visit planning, pre-visit lab, team-based care, so some really helpful modules. There's CME available both at Steps Forward and on the Prevent Diabetes Stat Toolkit. So I will stop there and we'll look to some of the questions. Okay, first question I'm seeing is there more success from referrals through the point of care process or the care management process? That's a really great question, and I'll tell you a little bit depends on the organization. So in our experience, the point of care process results in a higher conversion rate. What I mean by conversion rate is the percentage of people who receive a referral who actually then enroll in the program. So there seems to be something about having that conversation with the physician and kind of receiving that referral sort of at that moment that you're ready to receive it that results in a higher enrollment rate. But it's more difficult to reach significant numbers of people if you're waiting for them to come into the office. The care management approach can be very successful. It's a great way to reach a larger number of people, but expect that you'll get a bit of a lower conversion rate there. So you'll do more outreach that will result in a smaller relative percentage of referrals, but you could potentially achieve a higher number overall. So do more patients enroll if referred by physicians? And that's definitely a related question. So I'm not sure that I have we have a fair amount of experience. I haven't exactly tested this hypothesis. More patients seem to enroll if they believe the recommendation is coming from their physician. So it's very helpful for a physician to have a conversation with the patient, but also messaging or outreach that comes from the healthcare provider or that comes from the clinic that is sort of done in the physician's name on the physician's behalf. Dr. So-and-so is recommending that you attend this program. that appears to be pretty successful as well. So I think really the key piece is that the patient needs to understand that this recommendation is coming from the physician, even if it wasn't the physician who had the conversation with the patient. Do patients need to consent to provide their info to the LCP? So this is a question that is best answered by sort of your risk management and kind of compliance individual at your own organization. We have seen it go both ways. So I guess the conservative answer would be that the patient should consent, but many organizations interpret this as saying that when the patient consents to receive care, they're also consenting for their information to be shared with other providers who will participate in their care, and so they don't need to consent explicitly for this. But again, I definitely do not want to give any legal advice on this webinar, so talk to your own compliance officer to determine the process that's appropriate for your organization. Next question is, what interval do you recommend for progress reports? So I think that, and the question was, weekly seems too often. We agree. I wouldn't ask your lifestyle change program provider to be sending weekly reports. I would, we've generally seen around 8 weeks after enrollment, around 16 weeks after enrollment are good time points for sending reports. The program lasts for a year, but the sessions become less frequent in the second half of the program, and so at about 6 months, 9 months can be other appropriate intervals to send progress reports. It's really up to you if you want to see sort of weekly level data in that progress report, but the actual sending of the report probably only needs to happen about at week 8 and week 16. All right, another question was, where can they find a sample patient progress report? And I actually do not know if we have that available on our Prevent Diabetes Stat Toolkit. I don't think that we do. I will look into whether or not we can share that with attendees on this call. It's certainly something that the AMA has. If you reach out to the contact information on the STAT website, it's certainly something we can share with you. We're happy to share with anybody. And any other questions that are coming in? We're just quickly reviewing our question list. There's a question, are we allowed to use materials from these other sites versus the YMCA exchange? You can use really any of the publicly available materials, and I think it's a conversation to have between the healthcare provider and the lifestyle change program in terms of what types of forms are actually used between the organizations. Oh, good point here. So a listener made the comment, lifestyle change programs often find that people enroll when their doctor recommends the DPP, but find the dropout rate higher than those who had other motivators for enrolling. So please don't confuse enrollment with success or completion. Yep, that's a great point. Program success doesn't stop at enrollment. We do know that enrollment and completion rates really both drive success in the program. In my experience, I have not seen that patients who enroll because of their physician recommendation actually drop out at a higher rate, but it's possible you have access to some other data, but I think it's a very good point. And many of the lifestyle change program providers do some assessment of readiness, but to be very honest with you, in terms of understanding what drives success in the program and really what keeps a participant engaged in the program over the long term, I think we being AMA, CDC, the YMCA, others involved in this work, have some work still to do there to be able to advise you further on what really drives long-term participation in the program. All right, and I think that is wrapping up some of the questions that we've received. If we've missed any, we'll attempt to get some responses to you. I think that wraps up the AMA portion of today's webinar.